Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, my dear students and dear doctors. I am Dr. Ahmed Al-Hadidi, lecturer of gastroenterology and hepatology, internal medicine department, Tanta University. Today, we are going to talk about history taking from GIT patients. Okay. Simply, we are going to follow the same rules that we follow for every patient that we are going to follow the same rules that you follow for every patient already know before, and all systems. Okay, there is a protocol that we already follow for history taking in all patients. For GIT patient, we are going to follow the same protocols. We are going to take the same items. Okay, but just we are going to respect or give some concern to GIT patient. Okay, for example, of course, we know our agenda here. Our agenda today is to know what is the importance of history taking. Okay, then we are going to follow the protocols for history taking for GIT patient by taking personal history, complaint, history of present illness, past medical history, okay, family history, social history, and systemic inquiry. Okay, but only with giving some regard to GIT patient. Our agenda today again, okay, introduction and describing what's our goals, our personal history taking, chief complaint, history of present illness, past medical history, systemic inquiry, family history, and social history. Or this is the simple question. Is it important to take an accurate history? Is it important? Yes, my dear doctor, it is very important to take a history from the patient. If you ask yourself one day, why should I take history? Why I don't go directly for patient examination? I'm going to tell you taking history is very important. Why? That we are going to know. Because here, as I told you, or as we told you, privacy, if you took your patient's history, okay, good history of the patient taking will lead to mostly 70% you will reach to the diagnosis before examining the patient. Okay, but if you don't take history, 70% or even 90%, from 70 to 90%, you will not reach a diagnosis even after complete patient examination. So never go directly for patient examination without taking history. Okay, never go directly for patient examination without taking history. Sometimes the patient may be unwilling or unable to give history. For example, patient comatose, the patient is disturbed conscious level, patient in a coma, like hepatic encephalopathy, for example. Then, are we going to take to avoid taking or just to drop or ignore taking history? No, we are going to take history from the patient relative. Okay, never going to direct examination without taking an accurate history. Why? As I told you before, 70% after taking accurate history, you will reach to the diagnosis. But from 70 to 90%, if you go directly to patient examination without taking history, you will not reach to a diagnosis. How should we take history? First, good history taking, you must follow the same protocols and the same items you know before. You have to respect the patient, respect his privacy. No one, never allow anyone to listen what the patient is telling you. This is a confidential, okay, between you and the patient. Respect the patient's privacy, the patient comfort and dignity. Patient must sit in comfortable. His dignity must be kept, and put in your mind about his dignity. Don't expose him in front of any other persons. Okay, listen to the patient. Don't interrupt him. Use the same language of your patient and understand his language. You must understand his language. If the patient is not speaking the same language, you have to get a translator to translate what his patient is telling. Okay, you ask a patient question. Is it allowed for me to ask you? Of course you are allowed to ask the patient a question, but just simple question. Okay, and you should avoid what? Avoid leading a question, avoid distracting the patient, avoid allowing patient to distract you or taking you to non-important topics. Introducing yourself to the patient. You are a medical student, you are a house officer, you are a doctor specialist. tell the patient what are you going to do, tell the patient what procedure you are going to do, why you are going to talk to him, why you are taking history from him. Of course, you must dress professionally in your white coats. Use the patient name. Never ignore or tell or call the patient in his first item, of course, is to take a personal history. Okay, to take a personal history from the patient means that you take some items, of course, you must all kept in your heart, and you must know. You have to take the patient name, nationality, age, sex, residence, marital status, occupation of the patient, social habit, including important social habit of a medical importance, his social habit or special habit of a medical importance. Mostly smoking and alcohol you have to ask about, or you have to know. Okay, if she is a female, of course, you have to take her menstrual history. Personal history is very important, and regarding to GIT, the same as you know before, we have to ask about the patient name to gain his confidence, to talk freely with him, his residence, because some disease maybe have some area, for example, bilharziosis is here endemic in Egypt. Okay, other disease endemic in other countries like trypanosoma, for example, in North America, and so you have to ask about age of the patient related to some disease. Primary biliary cirrhosis, for example, common in a middle age. Okay, malignancy are common in old age. Okay, autoimmune hepatitis the same. For the same for the sex of the patient. Female gender are more liable for gallbladder stone and colitis. Okay, primary biliary cirrhosis also more common in female. Okay. Special habit, of course, of a medical important related to GIT. Why, for example, alcoholic risk for GIT patients. Alcohol may precipitate steatohepatitis, may precipitate atrophic gastritis. Smoking, like the same for gastroesophageal reflux, and malignancy, of course, the incidence increase with the smoking. So after taking this personal history, you have to write in one paragraph. Don't mention in items, just in one paragraph. For example, you can tell this is male patient, 70 years old, from Tanta. He is married. He is not working or retired. Okay, he is married. He has 3 sons. Youngest one is 15 years old. Okay, he have no special habits, and so it is only one paragraph to write. Next item is patient complaint. Must be mentioned in the patient own words. Okay, you have to take them no medical, as you have to take patient complaint from his own mouth. Okay, from his own tongue. Don't add a medical term. You have to take them short, specific, 1 or 2 words only. Don't give so many words. Just abdominal pain, like that, vomiting, nausea. Okay, losing weight, abdominal distension, leg swelling. You have to arrange them in a chronological manner by timing. Yani you have to mention what happened first. For example, patient have abdominal pain since 3 days, nausea and vomiting since 2 days, abdominal distension since 1 day, like that. Okay, this is complaint. And how to take complaint. Complaint variety, GI, gastrointestinal and hepatology system, including liver, pancreas, starting from alimentary tract from the mouth up to the anal canal. So many complaints are related to gastrointestinal disease. Each one of them you have to take in a separate, we will take and we will discuss with you as a separate entity later. Okay, like abdominal pain, heartburn, pyrosis, altered bowel habit, diarrhea or constipation, altered bowel habit, dysphagia, difficulty in swallowing, bleeding, GIT bleeding like hematemesis, melena, okay, hematochezia, hiccup, dyspepsia, vomiting, nausea, flatulence, abdominal distension. All those are GIT symptoms that we will be discussed later. Use your medical term, you start to use our medical term, and then we are going to analyze the complaint that we mentioned before. How to analyze any complaint? Of course, you will take each complaint by one, but in a general, as a general rule, you have to mention the onset of the complaint. When did it start? It is started 1 week, 2 weeks, 1 month ago, 2 months ago. Okay. And by the way, what is a complaint? Complaint is what's annoying, what makes the patient seek medical advice, what makes the patient come to the hospital. He come to the hospital because he has abdominal pain. He had abdominal pain, he had nausea, he had vomiting. This is the complaint. You have to ask back to analyze this complaint, to ask about its onset. When did it start? Its course, is it increasing, progressively increased, or decreased, or intermittent, partially decreased and then reappear again. Okay, what's aggravating? Aggravating يعني what is increasing or exaggerating or exacerbating these symptoms. Okay, like eating, for example, might cause related to vomiting and nausea, mostly after meal, related to meal. Abdominal pain related to meal. And so what is relieving by fasting, for example. Abdominal pain improved by fasting, improved by medication, improved by rest. And so we have to mention the onset, the course, the duration, aggravating symptom, relieving symptom, site of this, if it is related to special site of this symptoms, its radiation. Okay. Yes, you might ask about any other symptom related to GIT. After finishing analyzing your symptom, you have to ask the patient. You can ask the patient, any other complaint? No, I don't have. If the patient telling you like that, you may hear ask him, don't you have, for example, leg swelling, abdominal distension? Is there is blood in your stool, discoloration in stool, blood in stool? You can ask him here after finishing present history. If the patient telling you, yes, I had, okay, you must put them again in the complaint and you have to analyze them in the present history. Okay. This slide here giving you some abbreviation just to remember how to analyze symptom. Each symptom you have to ask about. O stand for the onset, C stand for the course, okay, position and site, Q for quality, nature, radiation, relieving symptom, severity, time, A associated symptom like vomiting. Medical history, okay, you have to ask about past history of a similar condition. Okay, you have to mention by details what is the similar condition. The patient hospitalized, what hospital? Okay, what hospital, what medication, and what the diagnosis the patient did. Okay, if the patient have any surgical intervention like blood transfusion, for example, most very important here in hepatology patient, because blood transfusion related to blood-borne viral infection like hepatitis C, hepatitis B, okay, dental maneuver, trauma, and so. Also, you have to ask about diabetes, hypertension, systemic disease, any medication, HCV medication. Did the patient receive HCV medication? You have to mention in the past history. Antibilharzia drugs? Yes, you have to mention in the present history. Does the patient have allergy to any drugs, any medications? You have to mention here. Mention the systemic inquiry here as a separate entity. You have to ask the patient about any other symptom related to all other systems like cardiovascular, chest, general, neurological, and so. And when giving a verbal report also, if the patient is telling yes, you have to put them again in the complaint and the present history. If the patient tells no, I don't have any other complaint related to chest or cardiovascular, so you have to inform the systemic inquiry here. No significance finding, no significance finding. Family history to mention if there is any consanguinity, any similar condition in the family or other family member. For example, here we have autoimmune hepatitis. Sometimes more than one family member have the same. Primary biliary cirrhosis, the same. More than one family member maybe have the disease. Okay. Close contact for the family members, because some disease are infectious disease, like parasitic infestation, for example. Okay, maybe spread from one family member to another family member if they do have a close contact. We have to just mention if the patient if average socioeconomic condition or low socioeconomic condition. Why is that? Because some disease related to low socioeconomic condition, like tuberculosis, for example, like recurrent chest infection. Sometimes some people have recurrent GIT or infection for typhoid if they don't have a good or good sanitation or pure or clear water supply. Some families have recurrent typhoid attack, typhoid infection. Why is that? Because of low socioeconomic condition. So you have to mention if the patient of low socioeconomic, good socioeconomic condition or average, because some disease related to the socioeconomic standard of the GIT symptoms is abdominal pain. Abdominal pain is a subjective. The patient is feeling of abdominal pain. Okay, you as a doctor cannot tell if this patient is honest, really feeling abdominal pain or not. This is a subjective, not objective. Subjective means that the patient is telling you, I have abdominal pain. Okay, but you are not, as a doctor, you are going to tell this patient have abdominal pain. I see it objectively. No, it is a subjective feeling. Okay, mostly abdominal pain caused by stretching of the smooth muscle or organ capsule. This is the cause of the abdominal pain. It's very common complaint. Most patients come as outpatient or to the ER emergency by abdominal pain. Remember how to analyze the abdominal pain, as we told before or a few minutes ago. In the history taking and symptom analyzing, we have to mention, remember this letters, we have to mention the onset of the abdominal pain, the position or the site, the quality of the abdominal pain. Sometimes the abdominal pain starts with a few days or few hours. This is acute. This is the onset. It starts within this pain. A patient will come quickly to the doctor seeking for medical help. I have abdominal pain starting few hours, 2 hours ago, few hours ago, even 1 day ago. This is acute. Even 7 days ago, mostly it is acute. But sometimes patient came to outpatient clinic complaining from abdominal pain with him since 1 month, since 2 months. This is chronic abdominal pain. Okay, position site of the abdominal pain here. Is it abdominal pain related to? We have to know here. We are dividing the abdomen into 9 areas. Okay, we are going to tell it later. Site of the abdominal pain. Is it epigastric, hypochondrium, right hypochondrium? Okay. What is the natural of the pain? Natural means what? Mention type of the pain. How the patient will describe this pain. Is it stabbing, like knife stabbing pain? Okay. Is it stitching pain? Is it colicky, dull, aching pain, like gastroenteritis? Is it a stabbing pain? Okay, like pancreatitis, for example, or say, is it constricting pain? What is the patient site? When it is radiation, for example, the pain in the right hypochondrium radiating to the right shoulder, this is the pain of cholecystitis, gallbladder inflammation. Okay, pain in the right hypochondrium radiating to right shoulder, it is a pain of cholecystitis. Okay, for example, pain in the epigastric radiating to the back of the back, pain of pancreatitis, for example. Okay, what is precipitating or aggravating the pain and what is relieving the pain? For example, pain related to meal. Okay, mostly it is pain related to meal. It comes from GIT. Okay, but fixed pain not related to meal, mostly outside of the GIT. For example, maybe cardiac, inferior myocardial infarction. Epigastric pain related to meal, mostly from whether gastrointestinal or gallbladder disease. Okay, what is relieving pain? Fasting. Sometimes fasting maybe relieve pain. Sometimes in case of ulcer, like gastric ulcer, it is relieved, been aggravated by meal and relieved by fasting, like gastric ulcer. Okay, what is the severity of the pain? Okay, and what associated symptom? Is it been related to meal, not related to meal, associated with nausea or not associated with nausea? For example, pain character not associated with nausea and the projectile in character from CNS may manifestation. 2 types of pain. Give special concern, please. Give special concern to the patient side. Okay, as we are going to tell in details later. Is it acute or chronic? As I told you, what is the type of the pain? You have to know these items. Okay, we have to know these types of pain. We have to know these items in details. Okay, as we are going to mention. We are dividing the abdomen into 9 areas. It pain might here in the epigastric area. This is pain coming from stomach, maybe from pancreatitis, from inferior myocardial infarction, maybe referred from gallbladder. This is epigastric pain. Pain here in the right hypochondrium, upper right areas, upper right quadrant or right hypochondrium area. Okay, pain coming from gallbladder or coming from the liver here, like congested liver or malignancy in the liver, or from colon. Okay, right colonic flexure. The pain here in the upper left area or left hypochondrium, this is pain from spleen, okay, or pain from the pancreas, pain from splenic or colonic flexure or left side colon, okay. The pain here in the pre-umbilical area related to mostly intestinal gastroenteritis or referred from appendix, okay. The pain here in the suprapubic area related to whether from colon or from urinary bladder, okay. Pain here in the right lower area, maybe right iliac area related to appendicitis, maybe cecum, okay, inflammation in the cecum, inflammation in the appendix, okay. The same here, being here in the left lower area, mostly related to colon. So we have to know the site of the pain, and each site we have to correlate it with the underlying or the most possible. Is this pain is acute? Mostly acute pain is a surgical pain, like surgical appendicitis, surgical pain, like appendicitis. Sometimes it is medical, like DKA, diabetic ketoacidosis, or inferior myocardial infarction might cause epigastric pain. Okay, is it acute within hours or days, or is it chronic within months or years? But we have to give attention. Acute pain is an important because it might be surgical or it might be medical. Chronic pain, mostly it is medical. It is visceral type of the pain coming from the stretch of the viscera or distension of the visceral capsule. Okay, mostly this visceral pain is dull, aching pain, diffused, hard to be described. Some of the patient is telling I have like a colicky pain, colicky gastroenteritis, for example. I have a dull, aching pain here. Yani I cannot recognize its character. However, parietal or somatic pain come from irritation of the parietal peritoneum, and it is sharp cutting pain. It is sharp cutting pain. Okay, sharp cutting, stabbing pain, like appendicitis, for example, here, inflammation or peritonitis. Okay, referred pain. This pain is not felt from its original site. It is felt away from the original site in an area supplied by the same neural segment or adjacent neural segment. Okay, like pain referred to, as we told before, gallbladder, it will be referred to the right shoulder. Surgical abdomen, this is usually item referred to. This abdominal pain might be caused by surgical cause. Surgical cause, it is emergency cause that needs immediate or rapid surgical interference because it will be give a serious complication even to this if there is no rapid interference. Okay, this is what is known as a surgical abdomen, acute abdominal pain caused by surgical cause. This is a surgical abdomen. What is a surgical abdomen? It's acute abdominal pain caused by surgical cause. It needs rapid interference because if there is no rapid interference, bad prognosis, bad complication, it will be happen. Mostly this is clinical diagnosis. I can see this abdominal pain is a surgical or non-surgical. It is, for example, like peritonitis. Okay, usually intra-abdominal peritonitis is inflammation in the peritoneum caused by intra-abdominal catastrophe, like perforation of abdominal viscus, perforation of a peptic ulcer, perforation of appendicitis, appendix, abdominal abscess, severe intra-peritoneal hemorrhage. Okay, this will cause peritonitis. It is in this condition the patient will look ill, the patient will look toxic, the patient will have severe pain. The pain mostly have the patient have rigidity of the abdomen or rebound rigidity and rebound rigidity, tender even to light palpation just by touching the abdomen. Even patient pain with shaking the bed. This is a severe pain. So mostly I will recognize it from my examination and from the history. It is acute in onset. This pain is usually surgical acute. It is a severe type of pain. Mostly it will be a patient will look ill. This patient will be rigid. The abdominal examination will reveal rigidity, rebound rigidity, tender to percussion or light palpation, and the pain was shaky even from recognize it from clinical diagnosis. Okay. Surgical abdomen, as we told before, that needs rapid surgical interference, like acute appendicitis, like peritonitis, and also many surgical cause, intestinal obstruction, acute appendicitis. Okay, all this will need rapid surgical interference, and most of them will be recognized clinically, as we mentioned before. Sometimes we need to go for further workup just to get an accurate diagnosis about the cause and about it is a surgical cause. What we are going to do, we are going to do another further investigation, abdominal ultrasound, X-ray, plain X-ray erect in abdomen and chest to see if there is air under diaphragm. Abdominal ultrasound will reveal intraperitoneal free fluid, will reveal intestinal movement. Plain X-ray to reveal air under diaphragm in case of viscous perforation. CT abdomen with contrast, and so many investigation available for accurate diagnosis of